Welcome to the Yale20 video on hyponatremia. My name is Zach Nussbaum. I'm a PGY1 in internal medicine, and I put this talk together in collaboration with Dr. Asghar Rastegar, a nephrologist here at Yale and a world expert in fluid and electrolyte disorders. Hyponatremia is very commonly encountered in the inpatient setting, but can certainly be a difficult topic. So the goal for this talk is to try and provide a relatively straightforward way to approach the problem that's applicable on the wards and that doesn't rely on the complex and frankly confusing algorithms that we've all been exposed to at various points during medical school. So the outline for this talk is as follows. We're going to start by going over some basics and touch on background physiology. We're going to go through classification and etiologies of hyponatremia. We'll go through clinical assessment and diagnosis, and we'll do this primarily by going through cases. We'll talk about treatment, and then finally we'll wrap up with some take-home points. So let's start by reviewing some useful basic principles. First and foremost, hyponatremia is a water disorder, not a sodium disorder. When approaching a patient with hyponatremia, you should always ask the question, why is this patient retaining excess water? Or put slightly differently, why are they unable to excrete free water? You should never ask the question, why is this patient losing sodium? That would be a misleading approach. It's also important to emphasize that the sodium concentration, in and of itself, says nothing about the volume status of a patient. You can have 3 different patients, all with the exact same serum sodium concentration, with 3 very different volume statuses. The volume status is best determined through physical exam. Sodium content, on the other hand, does correlate with volume status, but content and concentration are very different things. Now, since we've established that hyponatremia is a water disorder, let's spend the next several minutes discussing water homeostasis and regulation of plasma tonicity. The plasma osmolality can be calculated by multiplying 2 times the sodium plus the glucose divided by 18 plus the BUN divided by 2.8. Now, as a minor point of clarification, the plasma tonicity and plasma osmolality are actually slightly different. Plasma tonicity is otherwise known as effective plasma osmolality and is calculated as well by adding 2 times the sodium plus the glucose divided by 18, but does not include the contribution from urea. And this is because urea is an ineffective osmol. It equilibrates freely across cell membranes and thus does not influence the shift of water in one direction or the other. Plasma tonicity is tightly regulated between 275 and 290 milliosmoles per liter, and this is achieved almost exclusively through the action of ADH, which is a hormone produced in the hypothalamus, stored in the posterior pituitary, and released into circulation in response to rising serum tonicity. And ADH works by increasing water reabsorption in the distal nephron, and thus acts to lower plasma tonicity. When plasma tonicity rises, ADH is secreted and causes increased water reabsorption, which brings the plasma tonicity back down to normal. And when plasma tonicity falls, ADH secretion is shut off such that free water is excreted in the kidney and plasma tonicity rises back to normal. So the key take-home here is that plasma tonicity is not regulated by changes in sodium handling, but rather by changes in water handling, and the key regulator of water balance in the body is ADH. Now, what we didn't mention in the last slide is that there's one other factor that can contribute to ADH release, and that's volume. In particular, decreased effective circulating volume can lead to what's known as non-osmotic ADH release. So what do we mean by effective circulating volume? A good way to think about it is as the amount of arterial fullness. Arterial fullness can be decreased in 2 ways. 1, there may not be enough volume on the arterial side. Or 2, the volume of blood in the arterial system can be perfectly normal, but there can be arterial vasodilation. In either case, clinically significant decreased effective circulating volume, or arterial fullness, should manifest with some degree of absolute or relative hypotension. Now, as it relates to hyponatremia, we are concerned mostly with states of decreased effective circulating volume. And what's most important to understand is that decreased effective circulating volume can be seen in both states of hypovolemia and hypervolemia. It's a bit more straightforward with volume depletion. The patient is volume down, and there's simply decreased blood volume in the arterial system. It can be a bit more tricky with hypervolemic patients. Two common examples of disorders associated with hypervolemia but decreased effective circulating volume are CHF and cirrhosis. In CHF, patients sequester the majority of their extracellular fluid in the venous system and in the interstitium as edema. As cardiac output drops, less volume is pumped into the arterial system, leading to decreased effective circulating volume. In cirrhosis, much of the extracellular fluid is sequestered as ascites, but in addition, these patients also suffer from systemic vasodilation, which in itself causes decreased effective circulating volume, and advanced cirrhotics, even when not in shock, are typically relatively hypotensive. So how does this all relate back to hyponatremia? When the effective circulating volume falls by about 7 to 10%, ADH begins to be secreted regardless of plasma tonicity, and this is called non-osmotic ADH release and is a very important mechanism in both the development and the maintenance of hyponatremia. So let's wrap up this first section by highlighting the approach that one should take when faced with the hyponatremic patient. You should first ask yourself, why is the patient unable to excrete free water? And then thinking more physiologically, you should then ask yourself, why is the patient unable to suppress ADH secretion?